So, good morning, good afternoon, and good evening to all of you who have joined us today for this Constellations Fest fireside chat with Maia Szalavitz. And thank you so much for making the time to join us today. And thank you specifically to Harm Reduction International for making this event possible. My name is Sheila Vakharia. I'm the Deputy Director of the Department of Research and Academic Engagement at the Drug Policy Alliance. The Drug Policy Alliance is a US-based advocacy organization working to end the war on drugs by changing policies at the local, state, and federal level. And it is my pleasure to interview Maia Szalavitz today about her latest book, Undoing Drugs, The Untold Story of Harm Reduction and the Future of Addiction. Maia Szalavitz is a neuroscience journalist and a best-selling author who has been writing about addiction, drug policy, and neuroscience for over 30 years. Her work has been published in renowned outlets, including the New York Times, The Guardian, Time, The Atlantic, Scientific American, and others. Her last book, Unbroken Brain, was a New York Times bestseller, and we wish her similar success with her latest. And so before we get started, Maia, I wanted to invite you to speak a little bit about, what made you to decide to write this book at this moment, and what inspired you to move forward with such an undertaking, basically documenting the history of a movement.
I basically was kind of crazy, I think, but now that I've done the work, basically, I think with many of my books, it's like this book should exist. Why hasn't somebody done it? And I know over the years there were many people within harm reduction who were like, "Yeah, I'm going to write a book. I'm going to write a book." But oftentimes, if this is not your way of making a living, that never ends up happening. So I figured, okay, well, this it really needs to be done. And I felt like, harm reduction was getting a lot more attention than it had previously and becoming much more accepted, although obviously we still have a ways to go. But what was really cool about working on the book was just realizing how far we have come and how bad it was in the 80s and 90s, and kind of how far out we all were. But it was sort of a huge challenge. And it's always, when you write about something you care about and people you care about, that's always especially challenging. But I really knew it needed to be done. And I also felt like I had something to say about it because, A, I believe it basically saved my life. And B, I've been here from the beginning of the movement itself.
Yeah. And so that's a great transition for me. I love how when you open this book, you started with your own story. And, so many times when people write about a history, it's something that's abstract that happened to other people. And you found a way to weave your own experience with harm reduction before you even knew what it was into this story. Can you tell folks who haven't yet read the book a little bit about how you decided to weave this element in and how harm reduction saved your life too?
Sure, sure. So I kind of, because I have a perspective. And because I have a perspective, I wanted to be upfront about what that perspective is. And so what happened to me was that in the mid 80s, I became addicted to cocaine and heroin. This got me thrown out of Columbia. I was in a terrible state by 1986. I was in pretty bad shape. And so I was visiting a friend because he could go cop drugs, and I had been arrested. So I was really afraid of getting rearrested. So I would try to get other people to buy for me as much as possible. I was sitting in his apartment, and there was this woman there who I hadn't met previously. And I must have known her name at the time, but I didn't now. And so, anyway, I was sitting there and I had no idea I was at risk for HIV, even though, it was 1986 and I should have known. I read 2 newspapers a day. I watched TV news all the time, and I still didn't know. Anyway, she said, "Hey, like, if you're going to, you're at risk. And if you want to protect yourself, you should never share. But if you have to share, you should clean your needle twice with bleach and twice with water." And so ever since then, when I was injecting, I did that. because this was well before needle exchange existed in New York. And in fact, very, very few people in New York knew about bleach. She just happened to be visiting from San Francisco and happened to work for one of the organizations in the consortium that first introduced bleach as a way of cleaning needles to the streets. And I had no idea at the time there was a whole story behind this. And so I went back and researched it and found that. And I really wanted to know who that woman was, because she did save my life. Like, the guy I was about to inject with was HIV positive. And, at that time there was absolutely no treatment. And so, are they having sound problems?
I think someone is,
Okay.
but the rest of us can hear you.
Oh, okay, cool. All right, excellent. Right. So anyway, so I wanted to find her, but I didn't even know her name. I knew that she was like a white woman, basically, and she was from San Francisco. But I did also know that, like, at the time, there were very, very, very few people who had the knowledge that she had, and
Right.
also,
She was part of a small group of people, potentially, to find, to hunt
yes,
down.
yes. So that narrowed it down a lot. And eventually, after about 30 phone calls or something, or emails and stuff like this, somebody suggested that she might be the person. And so I finally got her on the phone. And when we first talked, like, she didn't realize that she was the person, because she was his girlfriend when I thought they were friends. I was not his girlfriend, so this was not an issue. But
Mhm.
anyway, she had come to New York to try to get him into rehab. And, at the time, most people who would do such a thing would be like, you must stop shooting up now because AIDS. And that would have been it. But she knew to meet me where I was. And so, anyway, after a lot of phone calls, and some starting to interview, who turned out to be a woman named Maureen Gammon, who also turns out to be from Liverpool, although she was not there when harm reduction was being founded. She was already in San Francisco. Anyway, so I did eventually find her, and it was just so great. And I'm going to San Francisco because the pandemic. I actually haven't been able to meet her in person since the '80s. So I'm going out there in a couple
Oh, for a
weeks.
reunion. You might.
Yes, so I'm really excited about this. I want to shake her hand, give her a hug, and thank her again. And one of the things that it was such a great example for harm reduction, because it's that power of a little act of kindness that is how harm reduction works. And you have no idea, you could save someone's life by, like, just those little actions. And so, but you rarely hear when your work, or something you did, actually had an enormous effect. So, we were both crying, and I imagine we actually meet in person. But it's a gift both on the part of the person who helps and on the part of the person who's been helped. And it, to me, offered a really good way in to the part of harm reduction that can be very hidden to people who don't do it. Because when you are doing harm reduction, you have to be present for people, and you have to be kind, and you have to be supportive, and people may be in great chaos. So from the outside, you don't see what can be going on there, but from the inside, just to be treated as a person, not as somebody to avoid, or somebody who's disgusting, or a horrible bad person who's the enemy in the drug war. Just to be seen as a person, and for somebody to say, I want you to live regardless of whether you use or not. That is enormously powerful. And so that was the beginning of the way to convey that in the book.
Yeah, absolutely. And I think that gives me a great transition to my next question, because you made reference to someone from Liverpool. I just wanted to give you a chance to acknowledge what it's been like to, maybe some of you don't realize, to be on a panel that was actually organized by the O'Hare sisters, and to maybe give you a chance to give a little bit of shout out to both our organizers, but really the role that their father and their family has played in this movement. And yeah.
Yeah, so Liverpool really is where the movement starts. Needle exchange first happens in Rotterdam and is founded by a person who injected drugs himself, named Nico Adrians. And he had support from local health authorities and local political activists. And so even before AIDS, he was able to get a needle exchange going in the Dutch city of Rotterdam. And so because there was an outbreak of hepatitis B, which is also spread by blood. So anyway, so they had started that, and Dutch policy has always been very interesting and very practical, and that is certainly a huge influence on harm reduction. But for it to become a movement, that started in Liverpool. And Pat O'Hare, Lynn Matthews, Alan Matthews, Peter McDermott, Alan Parry, all of them, and John Marks and many other people, but these are some of the key players, realized that Liverpool was at great risk of an HIV outbreak because it had really bad economic conditions, a lot of young people injecting drugs, a lot of unemployed people, and up the road 200 miles in Edinburgh, they had 50% of their IV drug users already infected. And so this was a huge news story in the UK. Everybody was freaking out. And they realized what happened in Edinburgh was the city had freaked out over this high rate of injecting drug use among young people because they also had factories closing and economic despair and whole nightmare there. But HIV got introduced earlier. And so before they knew it was out there, they decided, okay, well, we're going to crack down on needles. We're going to arrest more users. We're going to shut down the methadone program because abstinence is what is needed. And they created the perfect conditions for an HIV epidemic because fewer needles, more people sharing them. And so Liverpool knew that that was not the way to go. And they also had the advantage of the fact that in the 1900s, the UK had started a policy known as the British system. And this system basically allows doctors to prescribe whatever drug to treat somebody with addiction that they think is appropriate. Now, in the United States, we decided in 1919 that if you prescribe for the comfort of a person with addiction, that is not any part of medicine. It's not legitimate medicine ever.
Yep.
So we can prescribe for the comfort of people with pain, but if you have addiction and pain, no pain relief for you. Anyway, so the UK still has that system, although it's very much shrunken. And Liverpool still had a doctor who was actively prescribing heroin and cocaine, and that was John Marks. He got involved with a guy named Alan Parry, who had been hired by some of the people, John Ashton and some of the other people in the health authority, were all very concerned. And so they knew that the only way to make this work was to get people who were actively using or people who had recently stopped involved, get that voice heard, figure out what they needed, and get that to them. And so they started a needle exchange. They expanded prescribing. They expanded methadone prescribing. They had drug user groups. They had all kinds of things aimed at attracting people to get services and avoid getting HIV. And so pretty soon, this was like a worldwide success story, and they were very good at generating publicity. And they realized so in 1987, Russell Newcomb, who is also a key figure in Liverpool, he wrote an article called High Time for Harm Reduction. It was in a obscure newsletter, and the first printing of it said High Time for Harm Reduction. But anyway, so Russell named what became the harm reduction movement. And it was an incredibly powerful thing because once you start focusing on harm rather than on whether somebody's getting high or not, then harms associated with policy have to be taken into account. If the idea is we're reducing overall harm, we can't be killing people to save them, which is what we were doing and continue to do in many instances, unfortunately. So So they decided, okay, we're going to start having conferences. And Pat O'Hare and now his daughters have been organizing these conferences. They decided they needed to have a journal, which became the International Journal on Drug Policy. And Pat O'Hare edited it for many years. Peter McDermott edited it for a while. That was sort of the ideological and the philosophical part of harm reduction. Got into the scientific community through the conferences, and then through a lot of Americans who visited and began spreading the message here.
Absolutely. Thank you so much for that history, and also for helping to kind of draw some of those connections, those regional and country kind of different connections. Um, and in bringing, the harm reduction message to the United States, we had several notable people, including the person that you call the goddess of harm reduction, bring some of this message to the United States. Would you like to talk about who you call the goddess of harm reduction?
Sure. And somebody else gave her that name, but that is Edith Springer. And she's probably the person who single-handedly spread the message to probably more people than anybody else, because she spread the message to a lot of influential people who then followed up. So she was working at a research institution in New York related to AIDS in, I believe it was 1988. And Alan Parry was visiting the United States, and Edith's boss was too busy to meet with some random guy from Liverpool. So Edith met with him, and he blew her mind. He just blew her away, because she had started doing bleach distribution with an organization called ADAPT, which was run by a woman named Yolanda Serrano. And they were the first people to do a real program of bleach distribution in New York City. And at this point, we had 200,000 people who were injecting drugs, and half of them were already HIV positive. So this was huge. And it was a tiny organization with no funding. So anyway, they would go, Edith and Yolanda and their crew would go out to shooting galleries and public drug scenes and just bring their bleach, teach people to use it, tell people the risk they were at. And so when she heard from Alan Parry that, like, in Liverpool, we actually can give out the needles, and that we're prescribing heroin and we're prescribing cocaine, and we have this whole idea. Now, Alan did not meet Edith where she was. He just basically said, "You're wrong," which is not the best way to convert people, but it did happen to work on Edith, who realized that it doesn't work well and that we should do this another way. And she is just a genius at meeting people where they are. So if you are somebody who's like truly believes the 12 steps are the one true way, she can meet you there. And it's an amazing kind of skill to have, because she's not going to leave you there often. So anyway, so she sort of had this conversion experience. She went and visited Liverpool, and when she was about to leave, she got down on her knees in Alan Parry's living room, where he had a pink couch apparently, and she said, "I'm going to carry this message." And she did. And she, virtually anybody in harm reduction in the United States in the early days was either attended a training by Edith directly or was trained by somebody who was trained by Edith. And she did thousands of these things over many, many years. And many of the other leaders of the movement, including people like Amani Woods, who was an amazing Black woman who Edith said, and Imani agreed, that she was like her hardest student to reach ever. So Edith had many, many meeting her where she is kind of conversations about why harm reduction is a good thing and we should do it. And then Imani went out and spread the word in the Black community and converted a lot of people like Charles Rangel, the ultimate drug warrior politician who headed the House Narcotics Committee for many, many, many years, and who was one of Needle Exchange's biggest opponents at the time. Now, he didn't change till many years later, but she was able to reach people that, thought that sort of bought into the idea that, we need to be tough on people with addiction because that's the only way we're going to solve the drug problem.
Yeah, and thank you so much for both bringing Yolanda and Imani into this conversation, because I did want to acknowledge and recognize how one of the things that I think that you were able to do was begin to dispel this idea, at least here in the United States, where, white men are kind of often seen as the faces of our movements or who have gained real prominence in our spaces. And I did really appreciate how you actually, spent time talking about communities of color and women and folks who were involved in the movement from the beginning to affect change, many of whose names many of us have never heard before. And another one of these names was the name of Keith Kyler, who I was wondering if you could tell folks a little bit about.
So Keith Kyler was an ACT UP member. He joined because he thought the people at the ACT UP meetings were hot, which they were. And so he he had lost somebody, and that was why. But he was sort of like, oh, I don't know if I want to be an activist. And then he saw these hot people in leather jackets. So anyway, he soon became an amazing activist, and so he was himself a drug user, and he got involved with a guy named Charles King, who is a white guy. Keith is black. He comes from the South, King, and they did not seem at all like a likely couple, but they sort of met cute and ACT UP by like arguing with each other. And then, and after they went home with each other one night, that was it. They were for life. So anyway, so Keith was he was a founding member of what organization known as Housing Works, which is a big organization here now, and which really pioneered things of making thrift shops kind of upscale, but having people with experience work there, and doing all these kinds of cool things that made them be able to raise money in ways that charities associated with AIDS and addiction usually couldn't do, because the glam ones were all gay, unfortunately, at that time. Anyway, so they founded this group called Housing Works, and they were basically the first housing first organization. And what that means is that, quite sensibly, they don't think that you can probably stop using while you're still homeless, and that we should provide housing first, and not kick people out if they don't instantly become abstinent, or if they don't ever become abstinent. And we will provide supportive services so that they can help others. Anyway, so Charles King was sort of a 12-stepper in a way. Like he got the idea of harm reduction as something for people who were still on the street, and clean needles and all that he was on board with. But when he discovered that Keith was not quitting, he kind of freaked, because he's like, how can we have like active user on our board and blah 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 blah. And then they realized that like what Keith brought to the organization was so valuable, that if there were times when his illness got in the way, fine, they'd get a substitute, just like you would with any other disability. And so they kind of began to work out how you can employ people who are actively using, and why you should. It is still hard because we're so criminalized here, but Keith was such an important force in showing how that could work, and in providing compassionate care to people who were HIV infected at a time when that was pretty much deadly, and housing people who basically every other homeless organization at that time did not want at all, and thought there was no help. And they learned that you can do this. And now the housing first philosophy is even widely accepted by the federal government. So it has come from, we have to make everybody abstinent before we can house them, to realizing okay, maybe part of the reason they're not abstinent is that they're not housed. So, so it just works so much better, because if people's lives are better, they are going to be less chaotically using.
Mm-hmm. Mm-hmm. So, in talking about the transformation that some of these other folks kind of had to undergo from the 12-step thinking, abstinence only thinking, to becoming a harm reductionist, you yourself detail in the book that you had a growing process. So, on the one hand, you learned about how to sterilize your syringes as best you could with bleach, but there was still a part of you after you had achieved recovery where you still had a little bit of ambivalence. Can you talk about what that was like for you and what, helped you change and open your mind?
Yes. So I knew from the start that needle exchange needed to be done, because bleach wasn't enough. And you can screw up with bleach, and you still have to share. Actually, if you shoot a small amount of bleach, it won't kill you. But because they tested that, because they needed to know that before they promoted this, just
Sure.
in case somebody did it by mistake. Um, but it's not recommended. Um, anyway, so yeah, so I thought, okay, we need to, like, the slogan then was like, dead addicts don't recover. And we need to have all this harm reduction service so that we can lure people, every person, into complete abstinence, because that's truly the most superior state. Um, so in my own encounters with the people from Liverpool, I learned otherwise. And one of the first things I learned, was I had been on methadone briefly during my heroin injecting time, and it was a disaster for me because it was a lousy program and I was continuing to shoot coke. So basically, it was supposed to be a detox, but which, like, a 21-day outpatient methadone detox makes no sense, especially for somebody who was living with a drug dealer and selling drugs myself. But anyway, so when I did get into recovery, which I did through your standard 28-day rehab, and I was told the 12 steps are the only way. So I guess this is what the medical authorities are saying. So I better do this because I need to get better. So I did, in my usual intense and passionate way, completely throwing myself into it. But I always knew that at the very least, we need to do something to protect people who are still actively using. And so that's where I sort of started with harm reduction. And then over time, I learned that, wait a minute, actually, methadone and buprenorphine, now, they didn't have it then, but these two drugs we now know are the only two drugs, and the only proven treatment in the world that cuts the death rate by 50% or more if you stay on it. Now, heroin and Dilaudid probably work just as well, but we just don't have enough data to get the mortality stuff. But anyway, with the given that, the whole abstinence idea that you need, what I basically thought at the time was that, okay, like, you're kind of second class if you need methadone or buprenorphine
Mm,
to recover. Like, it's like, it's fine for them, but like they're missing out on the glorious joys of abstinence. And they're sort of living a low level life when they could be living like in like utter, abstinence bliss. Um, so I met some people who were on methadone that were like just as smart, just as emotionally available, just as present. And I started to read the literature, which again said, this is a very effective treatment and it doesn't make you emotionally dead or any of those other things that they claim. Because people still claim that, oh, if you're still on those drugs, you're still high. And they just don't understand that, no, you're not, because of tolerance. Now, you could still get high if you wanted to take it in a very irregular fashion. So you could, take your whole thing on one day, and, that would, but if you take the same dose at the same time every day, you can drive, you can love, you can work, you can do all the stuff. So that opened my mind. And then, I started to just learn the research and realize that some people do recover by moderation, even of their drug of choice. And that we shouldn't privilege abstinence from everything, because people need different things. Like
Mhm.
I happen to need antidepressants. And if they were illegal, I would probably be in trouble. But am I compulsively using my Prozac despite negative consequences? No, it makes my life better. Does it make me emotionally numb? No, it just turns me down from being emotionally up here in, crazy intensity and neediness. So, and it's like I am able to be more present by being less. And I think a lot of people don't understand that that is a really important, your baseline really matters. And so just because I have a different baseline than you doesn't make me better. And, if you can live without any, chemical assistance, which there's very, very few people do, almost everybody uses caffeine. And we all probably, almost all of us use sugar. It's just a silly moral purity exercise. And it took me a long time to get to that because I felt that I didn't want to jeopardize my recovery, basically. And I think a lot of objections to harm reduction come from the idea, well, if someone else can use in a controlled way, maybe I can, maybe I don't need abstinence. And that can be very threatening and it can be dangerous for people who do need abstinence. So it's a spectrum and people need to find what works for them. And we need to be kind to everybody and treat everybody as worthy of respect and dignity and all that good stuff, regardless of what substances they are in their body. Like, it's like we shouldn't be judging people by the content of their blood.
Yeah, absolutely. And, one of the things that I also kind of appreciated in your own personal story was your use of like online message forums and how in the early days of, kind of being online and whatever that looked like, part of that was like how you got new and different information than your typical sources. And, to this day, I think a lot of people find themselves looking to the internet for a variety of sources of information because unfortunately our governments aren't providing us with proper public health education. Our textbooks, the kinds of resources that are available to us really aren't practical for where we're at. So can you talk a little bit about
Sure,
how
sure, sure.
actually being online helped you?
Yeah, so I had a friend who founded one of the first, they called them BBSs for bulletin board services in New York. And this is around 1989, 90. And so it comes online in 1990. And so at this point, the only people who are online are friends of somebody who runs one of these things or deadheads because some of the band members were online in a place called The Well. And you could get good, you could talk to the band, you could get tickets maybe, so this rapidly deadheads came online very early because of this. The rest of the people were like academics of various sorts and computer geeks and all of this. So there was this real, you know, somewhat libertarian, somewhat, just this whole sense of openness to experience, where people who came online first were definitely the least anti-drug people you would generally find, except I suppose some of the techies were like, I must protect my brain. But
Yes.
anyway, and that's fine, whatever works for you. So anyway, I got onto this thing and there were these things. And, the early internet is so much better than it is now. Like you could talk, I would have the top half of the screen, somebody else would have the bottom. You just type, you see the other person's typing as it goes. No ads, no nothing, no evil companies data mining and there were all these like academic lists about one of the ones that I was on, this one called Addict L, and it was about addiction. It was supposed to be an academic and scholarly discussion of addiction, which was really a brawl over what is the truth about addiction, which was great because there were some of the top scientists in the world were on there. And then some of us kind of random 12 steppers, and we got our asses kicked. So, like, again, this was more of an Alan Parry style conversion experience because I just don't like being wrong. And so I really, really don't like being wrong. I am wrong sometimes, but I like to win arguments. And so, which is, I'm opinion writer. I should like to, hold on, let me just have a drink here.
Yeah.
Um, but yes, so I sort of got tired of losing arguments and switched to the winning side. And then became very good at that because I knew both sides so well. And I mean, I think this is a very similar thing to the way Michelle Alexander's New Jim Crow was so powerful, because she used to think it was a stupid idea. And she remembered thinking, that's exaggeration, whatever. And then when she researched herself and found out, wait a minute, this really is a racist system. It is not like doing anything to help drugs, and it's locking up a lot of Black people. She was able to tell the story of her own conversion in a way that would reach people where she was. And that also, it's an important part of the book, because when minority communities began to see that the drug war was not something that was fighting drugs, but was oppressing people, the cover for white people to support the drug war was ripped away. And so once that began happening, we began to see real change. And by the way, of course, we are not where we need to be. But coming from a situation where you couldn't even say marijuana legalization without getting fired, to having 18 states or whatever it is now legalized, and more coming online every day, to having a state decriminalize possession, which again, that would send the wrong message. You could never do that. Like, it's amazing to see how far this idea has come and how powerful it is. And that's really what I was trying to show in the book.
Yeah, absolutely. And I think, I'd love to take a second to also just kind of talk about how you told the story of so many renegades here in the United States, people who actively broke the law. And, we know that people are actively doing that today here in the United States and in other parts of the world, fighting for safe supply, fighting for overdose prevention centers or safer consumption spaces. And, one of the things that we've seen while we're continuing to fight these radical fights is that in some ways our interventions have also become institutionalized in a way that's kind of public healthified them and extracted them from their more radical roots. And I was wondering if you could talk a little bit about that, that a movement that was so grassroots driven by people who are marginalized, people who are impacted, what does it mean for you to hear institutions using that language, and what is gained, but also perhaps what is lost when that happens?
So Monique Tula has a great sort of way of thinking about this that she attributes to someone else who I'm going to forget. But anyway, the idea is that, if you are in a political movement, you want to go mainstream because you're going to have an influence. You're going to, really change things at scale. The problem with that is kind of the problem that you have when the indie band that you love, becomes huge. And then you're like, but they were mine. And they were so
I was
radical.
there first.
Yeah. And also just now they sold out, they had these ideals and I get it. There is a loss of some of the radical edge, and we need to be careful of that and try to be as preserving of the outsider voices that we were as we go along. But is it good that needle exchange is legal now in most places? Yes. Is it good that, we have massive naloxone? We don't have enough, but we are having more and more naloxone distribution? Yes. Is it good that, you have Joe Biden saying one of our key policies is harm reduction? Yes. Do we have to hold his feet to the fire so that they actually do that instead of just saying that? Also, yes. But it is very, it's a complicated thing. And, it's like when, this is going to sound insane, but I sort of feel like that a little bit about heroin. Like this was a thing that a few of us did, and now it's like, which is terrible, and I don't really mean, but you kind of
it's human nature then, right? On some level, to feel protective of the things you value, whatever that might be.
No, and I mean, of course, I don't but it's that same sensation, that same emotion that's around, doing something really edgy, and then everybody's doing it, it's boring. So, but in this instance, we want boring. We want. One of the things I think that is underappreciated about marijuana legalization is that when you take away that forbidden fruit aspect, it's just less attractive to kids. It doesn't mean that it's not attractive, but it loses some of that edge. And if you're looking for the edge, um, you know, that is an interesting thing. And I think that's part of why we haven't really seen youth rates go up.
Right. Right, absolutely. You make a great point. And I do like, that you've kind of said that, once as we see our interventions get institutionalized or formalized or gain some recognition, that the next natural step for us is to keep pushing, right? Not to sit back, but to push and to hold accountable, but also perhaps to broach that next taboo area to kind of keep the momentum up and to keep pushing forward.
Yeah, and it's also really important to recognize the possibility of a backlash, which some of the radical stuff can be used against you in. And I think, we're sort of starting to see that with a couple of books and a couple of authors that have come out lately, saying, oh, we can't do harm reduction because, homeless people or something. And, they need to go to jail. Now, it's very interesting also. The other thing where we have gone mainstream is Nora Volkov, head of the National Institute on Drug Abuse, the largest funder of addiction research in the world, is publicly favoring decriminalization. That we would have never seen. And she's like, she heads a National Institute agency, which is very political to get to be. You have to be very good at
very politics. Savvy.
Yes,
you
exactly.
Navigate a lot of the politics.
This is not how I am, but somebody who is good at moving their way through institutions says that decrim is what we need to do. And she's really one of the world's leading experts, although I do disagree with her on some things. But anyway, the point is just that that is an enormous thing. And so you have these people saying, but nobody can get treatment if we don't arrest them. It's like, the experts actually don't say that. They used to say that. They were wrong. But we realize that if we want to actually treat medical conditions, we don't arrest people for breaking their diet. We don't think that's a good way to change behavior. It really isn't. It just does harm. We can certainly use incentives to help people change behavior. And I don't think there's anything wrong with that, but people have to voluntarily want to be doing that in order to engage in that.
Yeah, absolutely. And this brings up another kind of question that I have for you in this current moment. Part of the reason that this conference is virtual and part of the reason why we've all become a bit more comfortable in the online atmosphere is because we're currently in a global pandemic. And I just want to recognize, that your book was released during this very kind of particular political moment that maybe has become over politicized in some ways and a little less public healthified, to continue to use my term. But can you talk a little bit about what it was like to know that you were going to be releasing a book in this moment and how you think the current pandemic has impacted the reception of your book and its messages?
Sure. So, the good part of it was that the term harm reduction began to appear everywhere, usually credited to gay men rather than people who use drugs who were also gay men. But
we got gay men too. Yes.
Yes. But it's just no, this came out of the drug user movement, Anyway, but the term was popping up everywhere because socializing people are not going to abstain from for very long. And we needed things like masks, distancing, Zoom, all of these things that we can use to reduce our risk, but that acknowledge that human beings need social connection. It is fundamental to our biology. So seeing that, it going out into the mainstream there was really good. Being stuck, not able to travel, not so much. And people still really don't know, about having in-person events, and people are sort of slowly creeping out as we get vaccinated. So that's been not so great. But On the other hand, with the virtual stuff, you can reach people worldwide in ways that you can't when you're just like, reading in a bookstore or something.
Yeah, look at us here today, right?
Yeah, exactly. But I mean, it's been also just a traumatic experience for almost everybody. I mean, certainly I've been incredibly privileged that I didn't have to go anywhere to work. And I was also extremely lucky that when the pandemic hit, I had done my research that required traveling. So I'd gone to Liverpool, I'd gone to San Francisco, I'd gone to Vancouver, I'd gone all over the place. And boy, did I travel a lot the year before everything shut down. And then suddenly, it's like, okay, you got nothing to do but write here. So in that sense, it was helpful. But it was interesting when I started writing the book, I was like, in no way will I allow this book to come out in 2020. I do not want that happening. And it had to do with the man who shall not be named, as opposed to the pandemic that we didn't know was about to happen.
Sure.
But I still think that was a wise decision. And I'm hoping that when the paperback comes out, next summer, I will be able to do more of the touring that I can't do now. Although I am very psyched to be able to go to California and Portland, Oregon soon.
Yeah, no, that's really exciting. I think that's really great. So I wanted to shift to a little bit about some of the other chapters in the book and some of the other perhaps unspoken or unknown kind of heroes of harm reduction and sheroes of harm reduction, if you will. You made sure to spend some time and put some special attention into the role of parents in this movement, both here in the United States and abroad. Can you talk about what impact that parents have had in moving this movement forward and affecting change, and why they're such important allies in our work?
Yeah. So if you look at and women in particular, if you look at the history of alcohol prohibition, initially women were huge supporters because they were tired of the men drinking up their paychecks or beating them. Rightly so. But then they began to see the results of criminalizing alcohol sales. And people were dying and gangsters and all of that. And so one of the biggest forces ending prohibition was moms and parents and people who were focused on the family. And part of the way the drug war has always worked is to say, what about the children? And that, if we allow drug use, we're going to destroy our youth, and this is going to be terrible. And anybody who advocates for your own selfish pleasure as opposed to for the kids, then there's something deeply wrong with you. So having parents say, this hurt my kid, this policy did not protect my child, in fact, this policy harmed my child, is enormously important. And I wanted to emphasize that by talking to some of the amazing parent activists, because especially now when so many people are just being lost to overdose, if those parents are saying, lock them up, we got to get those dealers, that can be an enormously powerful force
And it
for what
has
I believe.
been,
Yeah,
unfortunately.
exactly. Right. And so, but when you have parents on our side who are saying, wait a minute, this jail does not help my child. In fact, that in one of the instances I describe, they became introduced to heroin in jail, I believe.
Mhm.
There's more than one story of that in the book. This does not help. It does harm. We have better ways of helping. And for parents who lost a child to say, like, no, I'm not going to blame the other kid who was there and who
Mhm.
just as easily might have died because they were sharing drugs.
Mhm.
That's not going to solve this problem. The only way we can do this is to treat people humanely and try to understand, why are people so attracted, especially to opioids right now.
Mhm. Mhm. Yeah, thank you so much. Yeah, and I thought that that was a really important chapter for you to include. You also spent some time in the book talking about people living with pain and people managing pain. And can you talk about that nexus, which is one that has not gotten as much attention yet. You know, this is an entire community that intersects with our own. Many of our community members in harm reduction are living both with, you know, their drug use, but also partially to manage some pain. Can you talk about the ways in which our policies have directly and indirectly impacted these communities, and the opportunities that you see for us to actually do some coalition building and our shared interests?
Sure. So I have been concerned for a long time that what we do is just we have these wild pendulum swings regarding whether opioids work for chronic pain. And in reality, like anything else, they work for some people and they hurt other people. You know, antidepressants, some people are made suicidal, other people are really helped. It doesn't
Mhm.
mean that drugs are bad. It just means that you have to find the right solution for the right person. Um, and pain patients have just been ignored. It's like nobody wants to hear their voices at all. And I, as a person with addiction, feel really guilty that anybody would be denied opioids because I exist. And that's basically what's happening now. We've cut the medical supply since 2011 by over 60%. And we did nothing for the people who got cut off. We just were like, oh, well, we stock the supply, we'll solve the problem. No, what will happen is, as did happen, is the iron law of prohibition will kick in and people will be dying. I mean, we have seen more deaths from overdose since the supply was cut than we saw when it was rising. So this is not an effective policy. It's doing enormous harm, not only to people with addiction, but also to people in pain who, you know, I just don't feel anybody should ever be denied access to medication that helps them because addiction exists. You know, it comes from this place where addiction is the absolute worst thing that could ever happen to you. So you should just die in agony because that way your soul will be pure. No, 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 this is not okay. And I think a lot of people don't want to deal with people in chronic pain because it's painful. Because if you're at all an empathetic person, you're like, oh my God, like, and you want to help and you don't want to be
Mhm.
like, you know, and you, I think a lot of the reason people avoid it is like they think, well, oh my God, I don't want to think that could happen to me. So they are just being weak and it's not really that painful. And no, that is not true. Like, I think having lived through addiction, I know that it's not the worst thing ever. Like, you know, I prefer not being actively addicted because it wasn't very healthy for me. But, you know, like if it was a choice between like having pain, and risking relapse, like I would risk the relapse because I believe that it is at you are much more likely to relapse due to untreated pain than you are to treated pain. And if you have your pain treated in the medical system with honesty and openness about what works for you, you can make sure, like, okay, write the prescription for just 3 days. Let my husband handle the prescription. Use a lockbox. You know, only have it in the hospital. Like, I don't just grow a drug dealer because I like have been given opioids in the hospital. Like, it's just like the way we see this is so absurd.
Mhm.
And you know, the reality is that like at maximum 2% of the population has opioid addiction. Um, 70% of the population has been exposed to opioids.
Mhm.
So let's be real, guys. I don't care if Purdue said it. The truth is that fewer than 8% of people who take opioids long term for chronic pain will become addicted if you actually know how to define addiction. And I think one of the things that I do want to say for an international audience is that calling addiction dependence has been a massive mistake. I just published a paper about this actually, because, you know, the DSM, we say substance use disorder now.
Manual, sorry.
Oh,
So,
sorry. Yes.
just clarifying for our audience, in the United States, the American Psychiatric Association has a manual of psychiatric disorders called the Diagnostic and Statistical Manual. And just to clarify for our audience.
Yes. Yes.
Go
And
ahead, go ahead.
the rest of the world uses something called the ICD,
ICD, right.
International Classification of Diseases, which is put out by the World Health Organization. Anyway, in 2013, America decided that calling addiction dependence is dumb because addiction is compulsive use despite negative consequences. and dependence is just needing something to function and avoid withdrawal. So we all have various dependence on each other, and dependence by itself, if you can get a good supply of whatever you need, is not a problem. Um, it's a problem only when the risks and the dangers and the harm outweighs the benefits. And that's when you're compulsively using something despite negative consequences. So calling addiction dependence does this terrible thing of like making anybody who's taking medication, agonist medication like buprenorphine and methadone or heroin, they are still addicted and they are seen as just as problematic, even though their life may be totally perfect now and they're married and they're taking care of their kids and they're doing their work and they're, doing their art and whatever else they want to be doing. The seeing somebody who is flourishing as having a problem just because they need a substance to function, that's not the problem. The problem is when people are using things that are harming them. And so addiction is use despite harm. Dependence is just needing something to function. And so, like, when you call them the same thing, you misclassify people on medication for addiction as being still actively addicted. And you also misclassify people in pain who are physically dependent as being addicted when they're not. And this in the United States can have severe legal consequences because comforting people with addiction is illegal.
Exactly. I think Ruth has an excellent question, and one that is on an issue that's actually very dear to my heart. So Ruth asks, they work in tobacco harm reduction, and, smoking rates, related illness, and deaths among people who use drugs are way above the general population. They have higher rates of use and higher rates of harm, and this affects and costs lives. How can I build bridges with mainstream harm reduction, air quotes, and the problem that our usual harm reduction funders unfortunately aren't funding tobacco harm reduction, and so the industry directly or indirectly does end up funding a lot of the research. Can you talk a little bit about that nexus, the tobacco harm reduction nexus?
Yeah, that's a real problem because a lot of people who should be supportive of tobacco harm reduction are not, because they fear being tagged as, industry shills. And I have experienced this in terms of my saying that, most people with pain don't get addicted to opioids, and most people who get addicted were never prescribed the drugs legitimately in the first place. And then I'm like, oh, you're a representative of Purdue. No, I'm not. I'm not paid by them, anything like that. My apartment would look a lot different if I were being paid by them. But I'm not saying my apartment is nice, but yeah, it's a problem. And I think this is a real divide within the public health community. I remember I actually had a letter. I think it was in the New England. No, it was public life. It was a big publication. I wrote this letter because they were saying we should never publish tobacco harm reduction papers. I'm like, will you publish needle exchange papers? Like, I mean, like you can't have that split like that. Now, I think there's certainly some questions because vapes have not been used as long as, current. We don't know the long-term risk. We certainly know that the long-term risk of tobacco is worse. But I think some people also are a little bit afraid to support it in the sense of that, like, what if it comes out that there's something really harmful? So I think it is definitely helpful to talk people through the contradictions. And so, letting them know that, like, if you're supporting clean needles, it's kind of weird not to support vapes. And, we can disagree on the, relative harms or whatever, but we need to come up with a way to minimize the harm done by cigarettes to people with addiction, because actually, I mean, this is pre-fentanyl, so maybe it's not true anymore, but in the past it was certainly the case. Most people with addiction died from smoking, not from heroin.
Yeah, and I mean, I think you bring up a really good point about this kind of conflation of like industry interests, public health interests, and the valid reasons that many of us have for being skeptical of what their motives are. And unfortunately that we're beholden to these institutions on the same hand, right? So like, I think when it comes to opioid use, absolutely, the skepticism that people have towards big pharma, yet on the other hand, wanting to increase access to a regulated supply, right? And then on the one hand, having skepticism about big tobacco creating kind of this problem, but then also understanding that they have also, for better or for worse, been at the forefront of supplying and funding research on safer products. And then I would also even add that another intersection that we see is big marijuana or big cannabis, right? Policy change to reduce the harms of marijuana prohibition on people's lives, where here in the United States, 40% of people arrested for any drug charge in the United States are being arrested for a marijuana related charge, even as states move forward with legalization. And so, regulation and legalization should be a huge, huge harm reduction advocacy component, at least in the United States, because you want to take the teeth out of the drug war, marijuana is the place to start. But then on the other hand, we've got people who have their reasons to be skeptical or to be reluctant to advocate for legalization because they see what happens when industry gets involved. And I think that this is a very, big and important area for us to talk about. On the one hand, we who else is going to be our champions for these changes? But on the other hand, in what ways are we facilitating profits that could be distributed among the community differently, especially when we think of corporate tax rates and whatnot? And I think that this is a debate that we should continue to have, and it's one that we're all kind of grappling with. When
Well,
people, yeah,
the problem is American capitalism here. Like this is like if we were sensible about regulating these things, we wouldn't. I mean, it's still legal for me to send a like beautiful former cheerleader to a doctor with a quota of opioids that I need to have that guy get if I'm going to make a living. If I'm the cheerleader, which I'm not. But anyway, the that's not okay. That, part of the reason that this litigation is so crazy is that most of the stuff that they did was legal and is legal. It should
mm-hmm,
not be legal to promote addictive substances in advertising in any way. But because capitalism, that is not where we're going. I still believe, on a whole, legalization will be less harm because if you know the dose and you know the purity of something, you have a much better chance of using it in a safer way than if you don't. I think that, you know, I am not as worried about big marijuana as many people are simply because it is less harmful than alcohol. And if we're going to allow alcohol advertising, but do I think there should be alcohol advertising or cigarette advertising or, no. Um, of course, as a journalist, this would mean a lot less funding for the entire media. But I still believe that this is the correct thing to do. And I also believe that probably one of the roots of all evil today, in terms of how the internet is and how messed up things are, is having things rely on advertising for funding.
yeah, yeah, absolutely. And so I think this brings us to another question that I have. And again, I want to remind folks, please add your questions to the chat. We can see them as they come in, and I am happy to kind of toggle back and forth to introduce your questions into this discussion. We have still about 25 minutes left. But the question that I wanted to transition to, and I feel like we've been building to, is for folks internationally. Just within a few days, the United States tracked that we lost for the first time over 100,000 people to drug overdose deaths within a 12-month period since the beginning of this overdose crisis over 20 years ago. So in the 12-month period between April 2020, which kind of marked the beginning of the pandemic, to April 2021, we were able to compile provisional death counts nationally to find that we had crossed the threshold of over 100,000 deaths. And, roughly 2/3 of these deaths involved illicitly manufactured fentanyl. And, we've kind of mentioned safe supply a few times throughout this conversation, but I'd love to give you a little bit of time to speak a little bit about the importance of a regulated supply, but also for a moment to zoom outside of the United States and to look to our neighbors to the north in Canada, and for you to kind of weigh in on some of the innovative models we've seen developed there. And, what are your thoughts on these models? What are your thoughts about bringing those kinds of models to the United States? What do you see?
Sure. So, I mean, it's quite clear that, why do we have 200? Why do we have 100,000 deaths in a 12-month period? We cut the medical supply 60% and did nothing for people. And the research is coming in showing that if you cut somebody's supply, regardless of whether it's pain or addiction or both, they have triple the risk of dying of overdose. And given that we have, and also I think it's twice the rate of suicide. Given that we currently have 4 to 5 million American people taking opioids long term who are still at risk of being cut off, and that was down from something like 8 million. A lot of these deaths are due to people losing access to a medical supply. And if we were sensible before we cut the medical supply, we would have immediately, if we were going to do that, we would have immediately provided pain care for those who need it, addiction care for those who need it, and, really low threshold methadone or buprenorphine, or just prescribe what they're already on. It's like, I know that in the UK, there's an argument that, when we had really loose prescribing, like John Marks, et cetera, it wasn't as associated with a reduction in death rate as when you have the tighter, where you have to use it on site. I think that's a sort of ongoing debate. But we can certainly say that allowing heroin use on site medically, this makes people healthier than having to rely on the illegal supply. And one of the biggest arguments they're always making against harm reduction is that it's going to keep people using longer. No, it keeps people alive longer. There's no evidence that it keeps people using longer. And whether you think them using longer is a good or a bad thing, they're more likely to go into more traditional forms of recovery if they have access to harm reduction than if they don't. And so it's like a ludicrous argument to say that we're enabling them and we're preventing them from hitting bottom and we're doing all these things to keep, because it's just so good that you'll never stop. No, by the time you're seriously chaotically addicted, things are generally not very good. And one of the things that you see repeatedly when people do get a heroin prescription for the first time is it's kind of like you've dreamed of this all your life. If only this would happen, my life would be perfect and I wouldn't have to worry and all would be good. Now, nothing lives up to that. I don't care if you get rich, famous, whatever, it's still disappointing. And so now, if you're in the heroin situation, you have a heck of a lot of time on your hands because you're not chasing it anymore. And so suddenly the things that were, the chasing the drugs was getting in the way of, you can do. You can be with people, you can work, you can do whatever it is that you love. And so, so this means that it's not more likely to keep you in some kind of zombie state. What is certainly the case is that the most traumatized and the most mentally ill and the most severely addicted people are the most difficult cases. And we're getting better at meeting them where they are, not leaving them there. But we still, it's just some people have had really horrible things happen to them. And they are going to need a lot of support. And, they may never have non-chaotic drug use. But can they have a better life? Yes. And why should we deny that?
Yeah. Thank you. Valerie, I didn't know you were on. Hello. She would like the citation for the new data about tripling people's risk of overdose by cutting supply. Do you have any reference for that? Or
I totally do. I will I'm not going to be able to cite it off the top of my head, but if you email me, and I'll just put my email out right here, it's Maia, Maia, S like Sam, Z like Zebra at Gmail. I will be able to provide you the reference. And if I don't immediately answer, please follow up, because now I'm going to get a lot of emails probably. And also I already get a lot of emails. So I will be happy to help as much as I can, but sometimes they space.
Yeah, no problem. Also, Portugal was brought up in the chat. Can we talk a little bit about Portugal now? An incredibly heavily discussed topic. Portuguese drug policy, and also the ways in which we've seen, jurisdictions here in the United States. The Drug Policy Alliance. We worked very closely with advocates on the ground in Oregon to pass Measure 110 to decriminalize. Can you talk a little bit about not only how safe supply and the need for a safe supply is an important part of addressing overdose, but also the broader idea of decrim and kind of what that can look like and what that means?
Right. So, contra people who have been making these claims, whose name I'm not going to state, Portugal has indeed decriminalized drugs, and they do not rely primarily on policing to deal with their drug policy. The way that decriminalization works in Portugal is that, if you happen to get arrested for possession, which you kind of have to be a real pain in the butt for that to happen in the first place, because they're not out searching. But if that happens, you will be brought before something called a dissuasion committee, which has a social worker, a lawyer, and one third person that can be different things. And they will basically see if you have a problem. If you're evaluated to have a problem, you'll be recommended for treatment appropriate to that problem. But if you don't go, you don't go. That's it. And this is similar to what is being started in Oregon. And the idea really is that arresting people is not a good way of diagnosing. And that, there's absolutely no evidence that locking people up for possession of drugs does anything other than raise prison costs, increase overdose, and increase HIV and suicide, and probably all kinds of other bad things. If you look at the association between the number of drug arrests that a place does and the amount of overdose, amount of drug use, amount of addiction, there is no relationship. In fact, there's probably a negative relationship with overdose if you're jailing a lot of people, because you're going to, if they have a tolerance, they're going to lose it since you're not providing treatment. Mm-hmm. And so this whole idea that like we can use this like gross mechanism of arresting people and locking them up to like solve a health problem makes zero sense. The Portuguese system seems to be working quite well. It did not increase drug use any more than in neighboring European countries that didn't. And this idea that like actually they're secretly using policing is just not the case.
Yeah, no, thank you.
Let me say one more thing about safe supply. So I think what you have to do when you're doing safe supply is kind of get the balance right between control and threshold, because you want some control because you want to try to like minimize harm, but you don't want too high a threshold. And so figuring out, and it's probably going to be different for different people, but figuring out. Can you
clarify what threshold means? Not everyone is
so basically, our methadone system and a lot of our buprenorphine treatment in the United States is what you would call high threshold. And what that means is that you got to piss in a bottle. You got to show up every day. You have to do all these things to get your medicine. A low threshold program, on the other hand, is just like, here, take it, you're good, as much as possible. And the idea of a low threshold program is kind of to be like as attractive as the drug dealers. So like,
and is accessible.
Yes, and ideally more accessible and minimally invasive. Now the thing is that if you are sort of looking to stabilize people and help them become less chaotic, sometimes people do need structure and they actually want it. And so there's still a role for higher threshold places for people who want the goal of abstinence or of no use of things other than prescribed. This should not be imposed on people, but you need to, it is kind of helpful to learn new skills in order to control or abstain. And so having high threshold things is not necessarily bad. It's just that they need to be targeted to the right people.
Right. And it's about options at the end of the day, is what you're also saying, right? Is tailoring and not having a one size fits all approach, but really responding to kind of where people are at and what structure and support they might need to
Yeah.
succeed. Yeah, no, absolutely. Before I forget, I also wanted to acknowledge, and you had pinged me earlier to make sure to ask you about this. Can you talk about the chapter that you entitled "Any Positive Change," and what this means for the movement, what this means in terms of our history, where did it come from, and what do you want people to understand about this? Any positive change.
Sure. So that comes from a guy named John Seiler at the Chicago Recovery Alliance. And he's very important in the history of recovery because they realized very early on that, harm reduction is kind of redefining what addiction is, but it also needs to redefine what recovery is. And that's why they called themselves the Chicago Recovery Alliance, even though they are a harm reduction organization that mainly does needle exchange. And so they were like, okay, well, if we're not going to define recovery as abstinence, how are we going to define it? So they sat down in a restaurant and they're like, okay, we're going to fight this out. And then John Seiler first thing says any positive change. And nobody could come up with a good argument against that definition. So that's what they went with. And it's any positive change as defined by the person who's making the change. So that is a completely, as you would say, user-friendly definition. And I think, the only problem that does run into is for people in abstinence recovery who kind of base their status within the world on how long they've abstained continuously for. And some people find that helpful. So I would just be more people have to define recovery for themselves. And it may seem too loosey-goosey to you to say any positive change, but if that's what's working for you and you are making those changes, yeah, why not? The abstinence people would say, well, they might be diluting themselves and not really changing. I'm not going to go there. People are going to, figure out their way. And the role of harm reduction, again, is to meet people where they are and not leave them there. And so, helping people to see that this change is working and this change is not working is perfectly appropriate, as long as it's done respectfully and with consent and all of this. So that is where any positive change comes from. It is a very revolutionary way of defining recovery, because it means that the guy at the needle exchange who just started using clean needles is in recovery, and the person who's 10 years completely abstinent from everything, including sugar, is also in recovery. I think the sort of recovery movement in the United States, which has been sort of working towards getting representation of people in recovery in policy, they came up with a very good way of dealing with this issue. And they basically, so when people introduce themselves, I'm Maia, I'm a person in long-term recovery. And for me, that means I don't take cocaine and heroin. And so that way we can, meet people where they are. They can have whatever definition of recovery works for them. And you shouldn't be judging them. It's
Yeah. So that brings me to, I think, a related concept that you also made space for in the book in talking about Alan Marlett, who had a tremendous impact on harm reduction and harm reduction research here in the US and abroad. And his work on really talking about what is known as, now more commonly known as, the abstinence violation effect, Can you talk about, because I see an interplay, right, between acknowledging any positive change, and that's also a resistance to an abstinence-based recovery, but the abstinence violation effect as a hazard of that kind of black and white abstinence only thinking. Can you talk about what
Sure,
that
sure.
means and how he came to describe this phenomenon?
Sure. So, you could also call it the fuck it effect, basically. And what it means is that, let's say you've decided, I'm quitting, I'm not smoking anymore. I have 10 days, yay, and I'm going on my 11th, and then I have a cigarette. Um, if I believe that I've totally blown it, this brings me back to square one, I'm not quitting anymore. Well, why not binge? Why not have a whole pack? Whether it's alcohol or heroin or whatever, if you believe like the first drink gets you drunk, as it were, and you think that like if you've had one, you cannot control yourself anymore, and that like you've already, you had 10 years, now you have 0 days. Um,
Start the clock all over again.
that is a real problem, and I have what I like to think is a solution to that, in terms of, if you are in abstinence recovery, I would argue that, okay, let's say you've been in recovery 10 years and you break your abstinence for 1 day. Okay, let's get another 90 days of abstinence, and now you get your 10 years back, because your 10 years did not go away anyway, and you should still be respected. And this idea that people need to be perfect to be in recovery is just problematic. And there's research showing, by Marlatt and others, that if you the more you believe that you are powerless once you break the abstinence, and that you've already blown it, the worse this abstinence violation is, and the worse your relapses and more dangerous they will be. So, I think that, you know, at certain points, it can be useful to be kind of rigid in the sense of, like, in very early recovery, like, you just want to sort of crack down and get yourself some distance from the problem. Um, you know, and other people may do it differently, but for me, it was definitely kind of useful to just get some time away, and you know, just get my sense back of who I was and what was going on and all of these things. Um, so I don't think it's necessarily, what I'm trying to say is that abstinence does work for some people, and we should respect that. Um, People should also be aware of the absence violation effect, so that if you do have one, you can say, okay, you know what, I don't have to binge, I don't have to like ruin my life again for this one thing. It was like, and what can I learn from this situation? Because the more you can see this as a learning process, and that you are still engaged in, and this is why any positive change is so helpful, the more you see that you are still a person in recovery, you are just working through whatever you need to work through, in order to stabilize yourself in your own definition of what's good for you.
Yeah, and I would add, so before my days of my PhD, I was a clinical social worker and did clinical harm reduction. And I think one of the things that I was, trained to kind of think about too was not to unconsciously as the provider or as the as the support person to uphold or to create a situation in which if someone were to return to use or have a slip, to make it so that they were so shamed and embarrassed that they couldn't tell me about it. Because I think one of the dangerous things about the black and white thinking of the abstinence only kind of thinking is that when people have built up a reputation, an identity around this abstinence-based recovery, people look to them as being, this kind of model to, role model of sorts. That a lot of people, when they do have a slip or return to use, that there's so much shame that they've let people down or that they can't talk about it. And how can we as harm reductionists, even when working with people in abstinence-based recovery, and if it's even ourselves working in harm reduction, how can we be kind to ourselves so that like if that moment were to happen, that like I could still ask for help, because it's long periods of abstinence that oftentimes it's that one time that they return to use that could put them at overdose risk, because their tolerance is gone. Not even necessarily because they said fuck it, but because they actually didn't remember how much they needed, or as we know now, that the drug supply is adulterated. And I think that as harm reductionists, we have to be careful of that too. We are just as likely to kind of perhaps create, expectations upon people that they don't slip, or that they don't struggle, or that they don't sometimes have challenges that they're grappling with. And we've lost so many people, even in the harm reduction movement, after a single or some secretive returning to use that eventually became chaotic or harmful, or was just because of the drug supply. And I think that that kind of thinking isn't just characteristic of abstinence only settings. I think we do it too.
Yeah, I mean, I think like it's really hard. And one of the things I also wrote about in the book was the situation of people who are actively using and who are realizing that it is becoming harmful, and realizing that they might need abstinence, but they've made this identity as I'm the active user in this group, I'm the active user, that can also, so,
Mm,
we can valorize both things. And I think, right, we just have to like try to minimize our judgmentalness, and try to have as many people involved in as many different perspectives, so that there isn't just the one guy who's the active user guy and that's his only role, or there isn't just the one abstinence person and that's like their only role, because
mhm,
that in itself, accepting people exactly where they are, will be helpful. And I think also there really is a problem with seeing abstinence or any other state of perfect health as like being, you're there, you don't have to work anymore, or like it's just, you know, to exalt it too much, basically, because
mhm,
we're all
mhm.
human, we all make mistakes. When you have something that can threaten your life, like an opioid addiction, you want to minimize the ones that could really kill you. But you know, it is really important not to activate that shame. And I think, for me, one of the biggest things I learned in recovery was just that hating myself for hating myself was really at the root of my addiction. Like if I just plain hated myself, that was okay. But hating myself for hating myself, this
Mm.
meta level and this intensity of just like being so ashamed of being ashamed, and hating of hating, and like you just can tie yourself in a knot with that stuff. And so the better you can be at being kind to yourself and being kind to other people. I mean, I do find it really useful to, if I start to feel like I'm treating myself badly, to be like, would you treat a friend like that? You know,
Yeah.
it's a really helpful sort of cognitive cue to be like, no, I wouldn't. That's wrong.
Yeah, no, totally. Also, Maya, I'm not sure if you noticed, but Pat O'Hare is here. Pat arrived a little bit into it, and you were speaking when he posted, but I just wanted to acknowledge that he is in the room if you wanted to say anything. And also, we have about 2 minutes left, a minute and a half left. So, any final remarks or anything you'd like to say?
Sure. So I want to say hi to Pat and recognize his really important work in this area, organizing these conferences and the journals, and just being one of the backbones of the movement in Liverpool. So I just want to say hi. And also, yeah, just I am awed by the people in this movement and the work that has been done. And I think, particularly in bleak moments, like is the case in the UK, and in the American South in terms of backlash kind of things, um, we have really come far. And though we do have a lot further to go, we should recognize the progress, because when you're in the day to day, you really can't see that. And you really just think you're treading water, and it's never, you are making change. It is slow. It is, but it does slowly, get better, I believe. And I've just seen that from writing this and from, watching you guys do your thing.
Thanks so much, Maya. So, on that note, I'd like to again thank HRI for hosting this event. And please stay on and join the rest of the Constellations Fest events as you can. The conference still continues. Make sure to go out and purchase Maia's book if you can, and follow her on Twitter. And have a great rest of the day. Thank you so much.
Thank you.